This talk will focus on the Focused Assessed Transthoracic Echo. This is a point-of-care application that primarily looks at cardiac function. Today we're going to talk about the FATE exam views. These are the three major cardiac views. And we'll also talk about how we incorporate the FATE protocol into our decision-making in both critical care and hospitalized patients. Some background about the FATE exam. Originally in 2004, this exam was described, and transthoracic echo for cardiopulmonary monitoring in intensive care. This was a study where they taught intensive care physicians how to use the FATE protocol, and then had them incorporate the FATE protocol into their daily routine, and they studied the outcomes. And the results of this showed that the FATE protocol provided usable images that contributed positively to evaluation in 97% of patients. More than a third of bedside echoes revealed new information that was not suspected prior to approaching the patient. And in about a quarter of the cases, the imaging was decisive in evaluation. When you're at that fork in the road about what to do with a patient, these images helped decide which way to take the therapy. There are several goals of the FATE exam. The first is to exclude obvious pathology. Secondly, we'll assess wall thickness and chamber dimensions, and these are the static dimensions of the heart. Third, we will assess contractility, or the dynamic dimensions of the heart, features of the heart. And fourth, we will image the pleura bilaterally. Because as we know, what happens in the thoracic cavity can impact on cardiac function. But the most important goal of FATE is to relate the findings to the clinical context. Every time we approach a patient with point-of-care ultrasound, we should have a question in our mind. The question being anything from, why is this patient hypotensive? Why is this patient short of breath? Do they need more fluid? Do they need diuresis? We should always approach the patient with a question. And then when you get your images, you should relate the findings to the clinical context of that patient. To go over the FATE exam acoustic windows. The first window we will talk about is the subcostal window. Secondly, we will talk about the apical views. And third, we will talk about the parasternal views. And lastly, don't forget, we will talk about the pleura. Subcostal. Approaching the patient from below the diaphragm to look at the heart has several advantages. Some patients are not able to obtain a transthoracic view because of hyperinflated lungs or being on a mechanical ventilator. Many times the subcostal view is the only view you can get. It's also the best view to assess for volume status of the inferior vena cava. We approach the patient with the low frequency probe with the orientation marker towards the patient's left. And what we'll do is we'll look up at the heart through the diaphragm. This particular view is the only one that uses an overhand grip. You have to have an overhand grip to be able to get the probe mostly parallel to the bed, to look up at the heart from below. And the image you'll get will be something like this. Right here we have the liver, the diaphragm. On the most anterior chamber of the heart is the right ventricle, and then the deeper is the left, and the right atrium, and the left. Another example is a different quality of heart function, but still the same view: liver, diaphragm, right ventricle, left ventricle, right atrium, left atrium. The bright white all around the heart is the pericardium. And of course you can appreciate the tricuspid and the mitral valve. To see this closer, we have the right ventricle and the right atrium, tricuspid valve. the left ventricle, the left atrium, and the mitral valve. And here's the bright white pericardium. You'll notice that the right ventricle in this view, in all normal views, should be smaller than the left ventricle. From this approach, we can look at the inferior vena cava, and what we're looking to find is the inferior vena cava in its longitudinal axis. In this case, the indicator, the orientation marker, goes from the patient's left towards the patient's head. So we're approaching the patient subcostal to the right of midline, where the inferior vena cava would be running through the liver. What we're trying to find is the IVC as it runs north and south. This is the view we would get. What we have here is the liver in green, the right atrium in red, and the IVC in blue running through the liver. You'll see lots of different descriptions of measurements of the IVC and how it relates to central venous pressure or volume responsiveness. That is a very complicated area, and so I'll try to simplify it here into some basic concepts. If the IVC is small, less than 2 centimeters, with greater than 50% collapse on inspiration, the CVP is judged, essentially runs 0 to 5. And this has been looked at in several studies. And these are spontaneously breathing patients. If the IVC is larger than 2 centimeters, but still collapses more than 50%, we're still talking single-digit CVP. But if you have a larger IVC with little collapse on inspiration, your CVP is probably in the 10 to 15 range. And if it's a large IVC with no collapse, then your CVP is probably higher. If you have dilated hepatic veins with no collapse, then you're likely looking at a CVP greater than 20. And what does this mean? Well, it does not necessarily indicate whether a patient's going to be volume responsive to know whether their CVP is 5 or 15. Only at the extremes of CVP can we assume volume responsiveness. So if you have a very, very low CVP, those patients will tend to be volume responsive in this shock situation. Or a very, very high CVP, it's much less likely that they would be volume responsive. But in between, it's a gray area, and more dynamic measures need to be assessed, which will be a topic for another discussion. So here you can see the IVC is small and collapsible. On this side over here, each one of these marks on the right margin is a centimeter. So you can see that this IVC is about 2 centimeters, but collapses almost 100% during respiration. So we would say that this CVP is less than 5, likely. You can also place an M mode line, which is motion mode. There's a button on the machine that says M mode. And you can place the line essentially about 2 centimeters back from where the diaphragm is located. And you can watch everything that happens along that vector over time. So what we see here is we see when there's positive intrathoracic pressure, the IVC is 2.79 centimeters. When there's negative intrathoracic pressure, or relatively negative, CVP, the IVC is 1.99. So that's about a 30% change. In that case, we have a greater than 2 centimeter IVC with less than 50% collapse. Now, CVP would be estimated at 10 to 15. Again, that doesn't necessarily say whether this patient is going to be volume responsive or not. Some other measures will need to happen. Here's an example of an IVC that's plethoric with very little respiratory variation. But the hepatic vein is not, this right here, this first hepatic vein is not distended. So here's CVP in the high teens to 20. I'm going to go to the apical 4-chamber views. Again, the indicator orientation marker is towards the patient's left, but instead now we're placing the probe where we would judge the patient's PMI to be. So the point of maximal impulse can be very varied with different patients. COPD patients tend to be more vertical. CHF patients can be very lateral. But feel for the patient's PMI and place the probe right at the apex, indicator mark towards the left. If you cannot get a good view, then you can try to position the patient on their left side with their left arm up. What this does is it brings the heart to the chest wall, moves the lung out of the way, and opening up the rib space by increasing, by lifting the left arm can often be helpful. So this would be the view. Obviously it's not going to be in this orientation on your screen, but we have excuse me, the left ventricle, the left atrium, the right ventricle, and the right atrium. If you rotate this around, this is the view. Left ventricle, left atrium, right ventricle, right atrium. This dot here is actually an error. That would be when we're not in cardiac orientation. When you're in cardiac orientation with the indicator towards the left side, the dot should be on this side. This was probably done in an emergency room or by a surgeon. Left ventricle, left atrium, right ventricle, right atrium, and the mitral tricuspid valves. We call this the apical 4-chamber view because you can see the 4 chambers, obvious. If you're going to get an apical 2-chamber view, then we rotate the probe counterclockwise 90 degrees and angle slightly towards the patient's left. In this view, we would get the anterior and the inferior walls, whereas before we saw the septal and lateral walls of the left ventricle. So the anterior of the left ventricle and the inferior walls and the mitral valve. You can see a little bit of the atrial appendage here. And this is important because if you're suspecting inferior wall infarcts or you're looking for wall motion abnormalities, gross wall motion abnormalities, you would not necessarily see the inferior wall very well in the apical 4-chamber view. So you do need to turn to look at that inferior wall. Here are the different vascular territories, the LAD, circumflex. So we've gone over subcostal and apical. Now we're going to talk about parasternal long axis. Now this is the only view where the indicator is towards the right shoulder. And this is in the cardiac orientation on the screen. What we're doing here is we're transecting the heart in its long axis, parasternal, so right next to the sternum. We typically start a rib space or 2 above the nipple line. And this is a CT view, but it's essentially the view you're going to see when you get a parasternal long axis view. We see the left ventricle and the left atrium. We also see the right ventricular outflow tract, ascending and descending aorta. And behind the heart is the pleural space. Note that we cannot see the whole right ventricle here, just a little bit of the outflow tract, so this is not the best view to judge right ventricular size or function. This is primarily focused on the left ventricle. Here's a good view. This is normal contractility. What you see are the left ventricle thickening and coming towards the midline. You can see the mitral valve opening here and the aortic valve as well. This is the descending aorta, and back here we have the pleural space. So this is an important landmark right here, the descending aorta. This basically divides, if you have fluid in the pericardium versus in the pleural space, this is the dividing line. Pericardial fluid will go anterior to the descending aorta, and pleural fluid will be posterior to the descending aorta. For example, this is a poorly functioning heart. You can see not much thickening, not much chamber dimension size change. But here's a pericardial effusion and a pleural effusion. Rotating counterclockwise from the parasternal long axis, you'll get the parasternal short axis views. This is basically looking at the heart as if you slice it like a loaf of bread. There's three different main levels that we look at. The first is the papillary muscle level, the mitral valve level, it looks like a fish mouth, and the aortic valve level. In terms of the papillary muscle level, this is the posterior median, this is the anterolateral papillary muscle. This is where the chordae tendineae are attaching to the mitral valve. And this is the level where we want to judge volume status. When we're talking about whether someone's dry or wet, or whether they have good contractility, papillary muscle level is where we're looking. Mitral valve level is the fish mouth, the anterior, the posterior leaflet of the mitral valve. And the aortic valve with the three leaflets. This line right here is the interatrial septum, and so we have the left atrium and the right atrium. And you can see a little bit of the tricuspid valve coming in there. When you rotate from long axis to short axis, you want to stop when the left ventricle appears circular. If you pass through circular and go back to oblong, then you've over-rotated. So you want to stop at the circular place. If you cannot get a place that looks circular for the left ventricle, then there's probably some pathology going on, which we'll talk about. The right ventricle should look like a crescent on top of the circle of the left ventricle. The fourth view is the pleural view. And what we're focusing on here is, with the indicator by tradition towards the head, we're focusing on the intersection between the thoracic cavity and the abdominal cavity with the diaphragm in between. And what we see here, again, indicators towards the head. So here's the dot towards the head. And if the dot were on this side of the screen, that would be towards the head. But always put the dot on the probe towards the head. And here we have the lung, the spleen, and the black fluid around the lung shouldn't be there. That is pleural effusion. So back to the goals of FATE. Number one goal was to exclude obvious pathology. These are things such as effusions, obvious gross valvular disease, dissections, which are rare to find on point of care ultrasound, but we should look for them anyway. Pulmonary embolus. So here is a subcostal view. We know that because there's liver here. And we see right ventricle left, right atrium left. And just standing back from this view, there's some obvious things that just jump out at you right away. The main thing that jumps out at me is this left ventricle is hardly squeezing. We don't see any change in the chamber size. We see very little thickening of the walls. We also see a pacer wire through here. So if you found this patient down, knew nothing about them, and ultrasound them right away, you know they have a cardiac history, a pacemaker, and poor cardiac function. And that does help guide your therapy. Here is a patient in shock, and you look at their inferior vena cava, you know that this patient needs volume. This subcostal view again, liver. We have the bright white layers of the pericardium separated by black fluid, and we have the right ventricle collapsing and diastole, and these are all signs of tamponade. So in the right clinical context, if you have a hypotensive patient and you find this, then that's very, very helpful. This was an interesting situation where a patient was in shock, trying to figure out the source of that. Here's the heart, basically pushed over onto the right side of the chest. This is the atelectatic lung, and that is a massive pleural effusion. You can use color as well to look for valvular pathology. And color in ultrasound is direction. So blue away, red towards. So if the probe is at the skin, you can use the color line over here to remind you that red toward and blue away. So any flow away from the probe will look blue, any flow towards the probe will look red. And here we can see in systole we have a blue back jet into the atrium, and that's mitral regurgitation. Similarly, we have the same on the right side, so that would be tricuspid regurgitation. We move on from the static, the obvious abnormalities to look at the static dimensions of the heart, wall thickness and chamber dimensions. And here we're looking for thickness, dilation, any obvious abnormalities like aneurysms. And very importantly, we'll always take note of the size of the right ventricle as it compares to the left ventricle. In the parasternal long axis view, what's notable standing out here is the thickness of the left ventricle. You may not have seen a lot of left ventricles, but generally the septum should be less than 2 centimeters. And here we have centimeter marks, probably about 3 centimeters. So that's a very hypertrophic heart. Here we can see large, 4 chambers, all large. The right ventricle is almost the same size as the left ventricle. The right ventricle is actually part of the apex, which typically it's mostly dominated by the left ventricle. And this would be 4-chamber dilation cardiomyopathy. Throwing this in here to show you normal. Here we have the left ventricle. The right ventricle is about 2/3 the size and more triangular in shape. And the atria. This is obviously abnormal. Almost if at first glance it looks like you've got something upside down, like this would be the ventricle, but you know if you're at the apical that this would be the left ventricle and this is the right, and these are the atria. This patient's chest x-ray looked like this, and this whole area here was their right atrium. So this patient actually had a very calcified mitral valve and tricuspid valve, had rheumatic heart disease and enlarged atria as a result. Remember when I said that when you turn to parasternal short axis view that you should be able to find the left ventricle as a circle. In this situation, no matter what we did, we couldn't get a circular left ventricle, and that's because the right ventricle is so huge that it's mashing, basically, essentially mashing the left ventricle. This is a very enlarged right ventricle. We have paradoxical septal motion, meaning when the mitral valve opens, the septum should move towards the right ventricle, but instead it's being pressed because the pressure in the right ventricle is higher than the left ventricle. When we see that flattening happening during diastole, it's volume overload. When it's happening during systole, it's pressure overload. In this case, this patient has both. We have a D-shaped ventricle here, and that is the classic that we see when we have pressure volume overload. Number 2 goal, looking at wall thickness and chamber dimensions, just a reminder that transthoracic echo is really the only bedside modality that can evaluate this and look at ventricular interdependency. You know, we have hints of it at CT scan and MRI, but the only dynamic way we can look at this at the bedside is by ultrasound. Just a reminder that M mode can be used if you really need to measure things. You can put an M mode line across what you are interested in measuring, and then press M mode, and you'll see over several seconds you'll be able to freeze this and use your calipers to exactly measure the diameter of things such as the inner ventricular septum and the lateral walls. Evaluating contractility. This is really a qualitative judgment. We're not planning on teaching you how to do exact ejection fractions. It's really not our role. That's the role for a formal transthoracic echo. This is a qualitative judgment. What we're looking for here is more normal, hyperdynamic, mildly reduced, moderately reduced, or severely reduced judgments. So in order to do that, have the normal view kind of emblazoned in your mind as the baseline. Again, we have the left ventricle thickening and coming towards the midline with the chamber size change 40 to 50%. We also have the right ventricle contracting. And to focus here, and we'll have other talks that specifically focus on the ventricle, but what we're looking for here is right here, where the tricuspid valve attaches to the lateral wall. That's the annular plane, the tricuspid annular plane, and what we're looking at is to see it move towards the apex in this direction about 2 centimeters with each systole. And that's because the fibers of the right ventricle are oriented differently. They kind of contract in a rotational motion, and it pulls that tricuspid annular plane up towards the apex. We call that TAPSE, or tricuspid annular plane systolic excursion. We expect to see that. By comparison, moderately reduced, here we have some thickening and some chamber size change, but it's not nearly what we would, when you look at normal, it's not up to normal. And the tricuspid annular plane here is not moving that 2 centimeters towards the apex. It's moving a little bit, but it looks more like it's being dragged instead of being squeezed. In hyperkinetic, we see the walls thickening and almost touching in the middle, and this is generally a patient who's either dry or very vasodilated. Mildly reduced, again, you see some decreased function, some decrease in the chamber size dimension. Moderately reduced we saw previously, and here's the severely reduced, where you see almost no change in the chamber size, almost no thickening. And look at the TAPSE here, there's almost no pull towards the apex. Again, the normal. Looking at the pleural bilaterally is another one of the goals. Here's an example. Essentially, you have diaphragm. You have lung up in here somewhere, but you have a pleural effusion with loculations throughout it. So this is going to help you if you're thinking about putting a needle in this for a therapeutic drain. You might think, this is a complicated chest space. This might actually need decortication or maybe the chest tube. Sometimes when you're looking in the abdomen, you can pay attention to what's going on in the thoracic space as it comes in and out of view. This is a view of the Morrison's pouch that you would get in a fast exam, but here's the diaphragm, and as the patient breathes, you can see coming in and out, you can see black, and black is fluid, so this patient also has a pleural effusion. This is the apical two-chamber view, so this is the inferior wall, anterior wall, mitral valve, descending aorta, and a pleural effusion behind. So just remember to look at your entire screen, not just what you're thinking of focusing on. This is in the abdominal setting, so the frame rate is a little bit slower and looks more granular. But again, here's the diaphragm, and right above the diaphragm, you don't see any black. You actually see what looks like liver. And we call this a mirror image artifact, which is what we see when there's air in the thoracic space instead of fluid. We have the ultrasound waves glancing off of the very reflective diaphragm, coming back up to the probe slightly delayed because of the glancing, and the probe interprets time as distance. So if it took a little bit longer to get up to the probe, then the probe is interpreting that there's liver deeper. So we have a mirror image artifact of the liver. That's normal. And the fifth goal is to relate the findings to the clinical context. So if you have a particular question in mind and you start your exam and you think you've answered your question, I encourage you to do all three views of the heart and the views of the pleural, because you may actually come up with some other information that guides you or reinforces your beliefs. There are a few cases. 42-year-old woman back in 2009 with H1N1 respiratory failure, severely hypoxemic, She was on 100% FiO2 with a PEEP of 18 on inhaled nitric. She developed hemodynamic instability and hypotension and tachycardia, but was too unstable to send for any tests. So at the bedside, we had to evaluate her for what was the etiology for shock. So this was the focus question we had, and it really in her it could have been any number of things. When we evaluated her, this is what we saw. Initially, you think about obvious abnormalities, chamber size and dimension, contractility, and you also think about the pleural space. Here, the right ventricle is larger than the left ventricle. That's not normal. The right ventricle should always be smaller. If it's the same size, then it's moderately enlarged. If it's larger, then it's severely enlarged. We also see something called McConnell's sign, and this is where you have the right ventricular lateral wall, which is fairly blown out and akinetic, but a hyperdynamic apex. And in some studies, this is thought to be very sensitive and specific for PE. There's a caveat to that. Patients with right ventricular infarct were excluded from that initial paper. So an RV infarct can look like this, but in the right clinical context, you may be thinking PE. So looking at this patient's leg, when we placed downward pressure on the femoral vein, we saw no compression, and she had a deep venous thrombosis. So in that context, with acute decompensation of hemodynamic status, a right ventricle that looked like it was under strain, and a clot in the leg vein, then we knew what we needed to do. So she got anticoagulated, thrombolysed, and actually did well, went home. 65-year-old man, case 2, with a known poor ejection fraction, coming in from a nursing facility with pretty bad Clostridium difficile colitis, lots of diarrhea, presented with hypotension and shortness of breath. The ER bolused him 2 liters of fluid, but there had been no improvement in his blood pressure, and he's actually a little bit more short of breath. So they called and asked on the phone, how much more fluid do you want us to give him? So, not knowing whether this is hypovolemic shock, septic shock, or cardiogenic shock, we said, hold on the fluids, we'll be right there. And what we did was we looked at his heart. You've seen this picture before. This was his 4-chamber dilated cardiomyopathy. And his inferior vena cava was rather plethoric. And when we looked at his lungs, which we'll talk about in another study, we saw something called B lines, which are these vertical comet tails extending from the pleural line. Those are equivalent to pulmonary edema. So his shortness of breath and hypotension was not hypovolemia from diarrhea, it was cardiogenic shock. So in that case, instead of sending him to the medical ICU for fluid resuscitation, he actually went to the cardiac ICU for dobutamine and Lasix and did quite well. So the answer there, no more fluids. Case 3. 80-year-old woman, severe hypertension history, came in rapid AFib. She had pulmonary edema on examination. ER gives her amio to slow her down and Lasix to diurese her. But her respiratory distress worsens. So what is happening here? In this case, what we saw was a woman with a very thickened heart, and this is slowed down so you can appreciate it. Very thickened heart, hyperdynamic. The left ventricular walls are touching. Almost no chamber. And a kind of thickened septum from her long-standing hypertension. So from the parasternal long axis view, we see the same thing, a rather thickened proximal septum and an empty chamber. But when we froze during the beginning of systole, we saw that the anterior leaflet of the mitral valve was basically stuck to the septum and obstructing the aortic outflow tract. And putting color across this, we saw the mitral regurgitation, this blue jet right here. So her pulmonary edema was due to mitral regurg from a very empty ventricle, and she essentially was displaying hypertrophic obstructive cardiomyopathy-like physiology with that anterior leaflet of the mitral valve stuck to the septum. We call that hokum. So we have the mitral regurg jet. We have pulmonary edema, but her IVC was empty because she was dry. So what she actually needed, instead of diuresis, was fluid. Fluid would open up that ventricular chamber, bring that septum away from that anterior leaflet of the mitral valve, and open up that aortic outflow tract. So she needed beta blockers in volume. And sometimes it's very hard to convince the bedside nurses or colleagues that that's what they need when they have obvious crackles. But in this case, 2 liters of fluid and her crackles went away. So the FATE protocol, to reiterate, fairly easy. We can do it. It's not hard to learn. We should be doing this. All of the critical care consensus statements say that this is no longer optional in the care of very seriously ill patients. And we will be doing it. I think it's on the boards now. It's considered mandatory in critical care curriculum. And I do believe that once you get comfortable with this, your practice will change. Thank you.